This presentation will address intimate partner violence, or IPV. According to the U.S. Department of Justice, IPV is defined as a pattern of abusive behavior that is used by an intimate partner to gain or maintain power and control over the other intimate partner. IPV can be physical, sexual, emotional, economic, or physiological actions or threats of actions that influence another person. This includes any behaviors that intimidate, manipulate, humiliate, isolate, frighten, terrorize, coerce, threaten, blame, hurt, injure, or wound someone. Women and men can be victims of IPV. However, 82% of victims of IPV are women. In this presentation, we will focus on women as the victims of IPV. Women ages 25 to 34 experience the highest rates of IPV. Pregnant women are at a higher risk for IPV, especially when pregnancy is unplanned. Homicide is the leading cause of death in pregnant or recently pregnant women. A significant portion of these homicides are committed by current or former intimate partners. It is important to note that IPV is highly underreported. To understand IPV, you must understand the underlying causes of it, which include anger, aggression, and impulsivity. Anger is an emotional response to perceived frustration, shame, or humiliation. It persists through life if it's not addressed. People use anger because it gets a response. The point of anger is about control. The angry person has lost control and they want to control someone else. People may hate being the victim of anger or violence, but if they respond to it, it teaches the abuser to continue to use this tool. Aggression is intentional behavior with the objective of causing harm, and impulsivity is actions performed with little or no regard for consequences. The victimizer may exhibit low self-esteem, extreme jealousy, anger, impulsivity, aggression, dual personality. The victimizer may have one personality to the partner and one to the rest of the world. Limited ability to cope with stress. Possessive. The victimizer may perceive the partner as a possession. The victimizer may be threatened when a partner shows independence. The victimizer strives to keep control and power. The victimizer often attempts to control all aspects of a woman's life. Remember that anger and aggression can be used to control. The victimizer may control money or transportation. The victimizer may struggle with alcohol or substance abuse. They may have experienced family history of abuse. They may have denial, or they blame the victim. Here are the characteristics of the victim. The victim may be of any age, race, religion, culture, or from various educational or socioeconomic groups. Culture is pertinent as some cultures, their roles are based on gender. Men hold the power, whereas the women are not respected. The victim may have low self-esteem. If they have been a victim of IPV for an extended period of time, they may contemplate suicide. They may be isolated from family and support systems. They may accept the blame for the batterer's actions. Feelings of guilt, anger, fear, and shame are common. The victim may not be able to act on their own behalf. They may feel helpless. They may have unwanted and/or repeated pregnancies. The abuser may be unwilling to use contraception to increase control. The more children the victim has, the more dependent they become. This slide addresses the cycle of battering. The first phase is the tension building phase. In this phase, the victim senses that the victimizer is losing tolerance for frustration. The victim may become nurturing or compliant to prevent anger from escalating. The victim may try to stay out of the way. Battering incidents may occur during this phase. The victim accepts the abuse and rationalizes victimizer's behaviors. This time frame varies. It may last weeks to years. Phase 2 is the acute battering incident. This phase is the most violent and is the shortest. Long-term victims know that once the acute phase is behind them, things will get better, but this is temporary. The victim may try to find a safe place to hide. The victimizer minimalizes the severity of the abuse. Help is only sought in the event of severe injury or if life of self or children is threatened. Phase 3 is the honeymoon phase. In this phase, the victimizer becomes extremely loving and kind. The victimizer promises that the abuse will never happen again, and he begs for forgiveness. This phase can be so short that it goes undetected. Oftentimes, the cycle soon begins again with renewed tensions and battering incidents. This is a great visual of how the victimizer tries to maintain power and control. A frequently asked question is, why does the victim stay? And there are many reasons. Maybe it's fear of retaliation, fear for life of oneself or children, financial reasons, lack of support network, religious reasons, or hopelessness. When a victim leaves an abusive relationship, the victim is at 75% greater risk of being killed by the abuser, and the abuse often does not stop once they have left. Clients should be empowered to make the decision to leave and provided with resources and referrals to maximize their safety if they choose to leave. Children who live in an abusive household are at risk for emotional, physical, and behavioral symptoms. They often become abusers as adults. Nurses must help to break this cycle. Children may become targets of abuse as they grow older, especially if they attempt to protect the victim from abuse. The nurse should help the client make a safety plan for herself and her child, but do not communicate this plan with the child as they may not be able to keep a secret. Let the child know that abuse is not okay and it's not their fault. Help the child find a reliable support system, such as a school counselor or a therapist. A good time for a victim to communicate with a nurse about trying to leave an abusive relationship is at a well visit without the abuser present. The client should be able to identify a safe friend or family member as well as a place to go. A code word should be created with friends or family to alert them of danger without the abuser finding out. The victim should keep an alternate cell phone nearby, as abusers may be able to trace cell phone numbers. The victim should memorize the phone numbers of friends, family, or shelters. The victim should hide an extra set of car keys and pack a bag of belongings. If in immediate danger, leave without the belongings. The victim should attempt to take evidence of abuse or violence. This may include threatening notes or pictures of injuries or property damage. Advocates at the National Domestic Violence Hotline can help to develop a safety plan. This slide includes some screening questions to identify IPV. Early identification is needed to minimize serious physical and mental effects. For some women, pregnancy is the only time they come into frequent contact with a healthcare provider. Early identification can reduce adverse health outcomes for the fetus. The American Nurses Association advocates for universal screening, routine assessment, documentation of abuse, and reporting IPV. The victim may present to the emergency department frequently, or there may be a time lag between injury and presentation for care. The victim may present with bruises at various stages of healing, lacerations, fractures, concussions, perforated eardrums, or burns over areas of the body. They may exhibit sleep disturbances such as nightmares or insomnia. The victim may have psychosomatic symptoms such as headaches, stomach pains, or nausea, vomiting. The victim may be experiencing anxiety, depression, suicide attempts. They may be struggling with substance abuse. The client may not tell the truth about their injuries. They may try to keep their injuries a secret in an effort to protect their partner, or they fear their partner will kill them if they tell the truth about their injuries. The client fears for their safety or the safety of their children. They may verbalize there's no way to get out of a relationship. The abuser may refuse to part from the woman. They may stay close and attempt to answer questions that are directed at her. After identifying a victim of IPV and starting to develop a plan of care, we are able to look at a number of nursing diagnoses. Social isolation, powerlessness, and risk for injury are on your objectives page. Expected outcomes. We want the client to identify a member of the support system. We want the client to identify a positive attribute about themselves. And we want the client to identify the first step of the escape plan. Nursing interventions include, first and foremost, maintaining client safety. That's a priority. Want to make sure that all wounds receive immediate attention. To interview the client, you want to get the client alone and in a private area. If the client is accompanied by the abuser, they will likely lie about the injuries. You want to ensure confidentiality of the information that's being provided, as well as explain implications of mandatory reporting laws. You want to take photographs for evidence if charges are filed. You need client's consent for this. Questions to ask include whether a battering incident has occurred before, whether the abuser takes drugs, whether the client has a safe place to go, and whether the client wants to press charges. It's important for the nurse to listen and use therapeutic communication. The nurse should affirm that the client is not to blame. Make the client aware of the variety of resources that are available. Resources include crisis hotlines, community groups for women who have been abused, shelters, counseling services, information regarding the victim's rights in the civil and criminal justice system. Knowledge of available resources decrease the client's sense of powerlessness. You want to develop a safety plan and make sure you document everything. You want to use the victim's exact words using quotation marks. Document discrepancies between the victim's and the family member's words, and describe the type and extent of injuries. How can we as nurses evaluate the plan of care that we have developed? Hopefully the answer to each of these questions is yes. Have the wounds been properly cared for? Have emotional needs been attended to? Have available support systems been identified and notified? Has a decision been made regarding the choices available? Ultimately, it is the victim's choice to leave, and as nurses, we must support their decision.